Hi, I'm Helen Bennett. I'm Divisional Nurse for Mental Health in Cardiff and Vale, and I have responsibility for all of our clients with who are out of area placements, but also I have responsibility for the budget to do with what we call continuing healthcare, of which the the NHS spends an awful lot of money on placements. So the reason we've been asked, and thank you to Johnny for asking us, is that things have changed quite dramatically, I'd say, over the last 3 years. Prior to the new health board being established, all clients who needed out-of-area support in whatever placement, it was the function of the local health board. And the local health board was separate from what was the NHS Trust. So the level of responsibility that the NHS Trust took for their clients was not good. So when the health board, the local health board and the NHS Trust merged and became a university health board, and that is the same across Wales, that's happened across Wales, there was a big focus on all of these clients who actually were out of area. Because for me, we should know all of our clients, we should know them very well, and we should have full responsibility for them, and that wasn't happening. And I think that was the same across Wales. There was also a focus on obviously making sure that clients were closer to home, if they could be, so that they were near families, friends, their local neighbourhoods, rather than being placed in England, Scotland, elsewhere. So that's where the story kind of begins, because I then took on responsibility within Cardiff for all of those clients and the continuing healthcare budget. There was a database. We did have a framework agreement with different providers. So we knew where our clients were, we knew who they were, but it was about that review process, and it was about taking personal responsibility, so that community mental health teams actually took responsibility for their clients. So you can imagine it was quite a culture shift, really. So a lot of work was done talking to leaders across the service, and trying to make sure that we got a much more coordinated approach to an individual's care, because it was about recognising that these clients needed to have regular updates and that they were in the right place to meet their needs. And that was the focus for me. It wasn't about the money, it was about making sure that clients actually were receiving the right care in the right place. It met their needs, but also it helped in their recovery. For a lot of clients, they'd been there quite a long time. So things hadn't been done to help them move along a trajectory to maybe independent living, or to a much more supported environment that actually allowed them to do what they should be doing, so maximising their potential. So it is around focusing on the needs of individuals, it's around the quality of care that is provided for individuals, and it's making sure that we know those clients, we know what their needs are, we know what their strengths are, we know what their aspirations are for the future. We've all got that, so our clients deserve that. So we're 3 years on. We now have all of our clients have identified care coordinators as in line with the mental health measure. All of our clients have been reviewed, and quite a large number of them are actually moving through to independent living. And community mental health teams are taking responsibility. It has taken a little bit of work to get them to move along to that process, but they are taking responsibility for their clients. Julia is going to talk you through the role of the Move On team, but and we've given you some charts. We didn't do a PowerPoint. We're we will go through those flow charts as to where things are for clients, and that they're very clear about the process, but also that staff are very clear about the process, because we deal with a lot of people. We have clients who are in maybe high secure, medium secure, and then step down into low secure, and we deal with the Welsh Health Services commissioning process, and they pay for people in high security and medium secure accommodation. And so we have quite an interface with them around when individuals are ready to step down. And so Julia is going to go through that pathway, and one of those individuals, we'll talk about a client in a case kind of study about how that has progressed to make it a smooth transition. Because obviously transitions are very difficult for individuals, especially if they've been in accommodation for quite a long time. And it's making sure that we work really well with providers to, enable that individual to maximise their potential, and also to make it a smooth, really smooth transition for somebody, so that their mental health doesn't deteriorate during that process. I'm going to hand over to Julia, because she does all the nuts and bolts. I do all the finance and all the putting the processes in place and making sure that things happen, but Julia does the day-to-day work for me, and so I'm going to hand over to Julia.
My name is Julia West. I started working in commissioning when I was in the Vale Local Health Board, and with the reorganisation I moved to the Mental Health Division of Cardiff and Vale Health Board and focused just on the mental health specialist placements that we have. As Helen mentioned, all of our patients now have care coordinators, and that's right the way through from high secure hospitals right the way down to community placements. And the role of our team has changed quite drastically over the last 3 years to fit very much with the patient-focused, needs-led model that Helen's talking about. The reorganisation has almost been the driver for trying to break down the historical working in silos and looking at, that's my bit of the budget, that's my bit of the care pathway, so how do I protect that bit and make sure that that bit's working okay? The Move On team's role spans the whole of the patient journey, right the way through the whole of the process. So our main role is around contract monitoring, making sure that there's a variety of placements available so that we are giving patients some choice where possible. That there's actually a choice of different ways to meet the need, different environments, because obviously patients respond differently to different environments. And obviously, although our aim is to make sure that the majority of people are in the Cardiff boundaries so that we can maintain good working relationships with our core NHS services, there will always be the mental health clients that have to remain out of area. So the Move On team literally is responsible for what it says, moving people through the whole of the care pathway. That includes inpatient NHS hospital beds and any commissioned health placement that's commissioned by Cardiff and Vale Health Authority. So we have probably about 160 patients at the moment that we are commissioning. That's not including those that we have joint arrangements with Cardiff Local Authority for, or that we've actually moved through to social care funding, but we obviously still have responsibility as the core NHS provider for services in Cardiff and the Vale. 3 years ago with the reorganisation, there was probably about 25% of those that I could tell you that I knew and that I'd met. I can honestly say now that 100% of those patients have either had contact with the care coordinator and or the Move On team within the last 3 months in some form or another, which to me has been a huge learning curve for us, an achievement and recognition that we are owning and taking responsibility for the services that we're commissioning. That it's not just about handing over the responsibility, it's very much about partnership working now to make sure that the patient progresses through their journey, supported appropriately by the providers that's in line with their assessed needs, and the long-term commitment of the NHS team that will be with them lifelong in one form or another. Helen mentioned that we had a framework arrangement. Many of you will be aware that there is now a secure services framework for the whole of Wales, which obviously we engage with and work with the secure services team to contract monitor in those placements. We also have our own framework agreement in Cardiff for high relational support. So that's very high level, 24-hour supported accommodation, much higher than your standard residential home, and staffed by carers that are skilled and experienced in dealing with the needs of mental health clients, some of which will obviously have had contact with criminal justice system, but all of which will have complex and enduring mental health needs. Our framework is under review at the moment, and again, there's been lots of learning over the last 3 years, and the focus now is very much on the partnership approach to how we move people through to the best place. My philosophy is that it isn't finance driven, but we do have a finance responsibility. I usually find that everybody around the patient has one core focus, which is the patient. If you get everything stacked up, that you are meeting the patient's needs in the best possible way in the least restrictive environment, the finance will work itself out. If you get anything wrong, if you either try to move the patient forward too quickly or you get the placement wrong because you go for the cheapest option, throughout the whole of the care pathway you will end up paying more anyway, whether because you've extended the length of the care pathway or you've actually ended up somebody relapsing to the point they have to go right back to the beginning. So our philosophy is that it is needs-led. The finance is secondary, but the very fact that it is needs-led usually means that the finances stack up. As soon as you try to cut corners, that's when you end up spending more money inappropriately. I think that you should all have some flow charts now, I believe. As I said, our remit covers the whole of the patient care pathway. The first one I'm going to talk about is the route for health funding application within the mental health division relating to inpatient hospital settings. And that can relate to either people in commissioned secure hospital settings or within NHS inpatient provision. Everybody, I hope, will be aware that the Welsh Assembly Government drive is that we all work to predicted dates of discharge. That includes whether it's an inpatient bed or a commissioned placement. And our aim is to have a predicted length of stay or predicted step-down date for everybody, whether in hospital or in a commissioned placement. This flowchart relates to somebody coming out of a hospital setting when it's been identified that they're approaching that predicted date of discharge. Ideally, we would like discussions to start a minimum of 3 months, preferably 6 months before the point of step down, because that's usually how long it takes everything to stack up. If you progress things quicker than that, you tend to raise anxieties, transition tends to be more problematic, and you do get hiccups along the way. Because of the finances involved, we do have to have a clear audit trail. I'm sure everybody is aware of the scrutiny that all public services as well as private sectors are under so far as finance goes. And our decision support tool process is an all-Wales process for determining levels of health funding. And it is an auditable process that is needs-led driven. A lot of clinicians hold their heads when they hear about the DST because it does look like a very onerous document. It's about 70 pages long. If you become used to filling it in and you know your patient, it's not as onerous as it looks. And it does mean that at the end of the day, it provides the evidence base for making sure that we are able to commission the right placement. So, assessment of need and all risk assessments are the starting point. All NHS services have to be exhausted before we look at any independent sector provider. And one of the benefits to me about the new organisation, the University Health Board, as opposed to the separate provider purchaser model that we had before, is that it allows for innovation and looking at a patient-focused way of meeting the need. Mental health patients are extremely complex. There are some that will fit into the available providers. There are some that do not fit, even if you try and squeeze the round peg into the square hole, and you're talking about compromising the service. The processes now involve applications for funding, coming through for an audit trail to the Move On team, and then they get discussed at a weekly divisional quality assurance meeting called an Escalation Meeting. Around that process is involvement of several senior clinicians, including consultant psychiatrists, senior nurses, therapists occasionally, colleagues from local authority. So it isn't just a funding panel, it is about looking at whether we've looked at the best way of meeting the patient's needs. And that will include looking at, like I say, innovative ways of meeting needs. It will look at existing NHS services, seeing if rather than somebody going to a low secure option perhaps, whether there's any possibility of putting a different kind of NHS support package around somebody in a high relational supported accommodation unit, rather than them having to go to a high level of security that they actually need, because that's where the therapies are available. And previously we have been in that situation that sometimes lady with PDs, their risks have been unable to be managed appropriately, and they've not been able to obtain the appropriate therapeutic input without that secure environment. We're now starting to look at different ways of working with the community PD service, but working very closely with providers to make sure that it's a shared risk management approach towards managing their care in the least restrictive environment. So the escalation meeting happens on a weekly basis, the aim being that there are no delays to the funding process, so that finances are never a reason for delaying transfer. Sometimes, if the audit trail isn't thoroughly there, or if there's a different NHS alternative that's identified, it will go back to the MDT for consideration as to whether there is other ways to be considered to make sure that the patient needs are met. If it's agreed that an independent sector placement is the most appropriate course, then alongside us getting ratification for the funding through our organisational continuing healthcare panel, we then go to, first of all, our framework providers, and if there's no suitable service available, then we'll then explore other options. Working alongside the MDT, and for me the big change over the last 3 years is the engagement of the care coordinator right the way through the process, from the discharge planning on the ward to the placement in the unit and to the first review meeting in the unit as well. So the care coordinator, although they may not have regular contact outside of that, they do have regular input at the review meetings and the discharge planning meetings. And I know that there's been several incidences where they've actually worked quite closely with patients that have been very well known to them in the community and have had difficulty establishing relationships with a new provider. I just need to get a copy of the Right. The second flow chart looks at what happens when somebody is in placement. So once the placement has been identified and funding is in place, we have a pre-admission assessment by a provider, and that allows us to cross-check with our funding application whether all of the identified needs and the desired outcomes are going to be able to be achieved. It also sets up a shared understanding between us as commissioners and the provider as to exactly what the expectations are, what it is that we are actually commissioning, and allows a framework for discussion on an ongoing basis. The transition plan, we hope, is the starting point to make sure that from the point of admission, we're up and running and already starting on the recovery-focused delivery of the care plan. So the transition plan, as well as allowing the patient or the service user to become familiar with the environment and start building relationships, it's also an opportunity to consolidate the pre-admission assessment, make sure that the sorts of activities that are available within the community in that area and within the placement actually fit with their activity goals and their recovery model goals. Once transfer has actually happened, we aim to have a review meeting at approximately 8 weeks. The aim of that is that with all health-funded placements, we have to take it back for ratification that the placement is actually meeting the need at 12 weeks to ensure that funding continues. And it also allows us, by that time, to actually regroup with the providers and say, have things turned out the way we expected? Do you need more input from the CMHT to help smooth the transition? What is it that we need to do to work together to overcome any barriers? Information sharing is very often key to making sure that the patient gets the best possible opportunities, and even things like sharing unified assessments historically has been problematic. So the more frequent and robust engagement does allow for sharing of historical risk assessments, personal knowledge of the care coordinator who has very often dealt with this patient in isolation in the community for prolonged periods of time and has a very good working relationship. So that knowledge can be taken forward rather than just being kept back in the community mental health team. We aim to try to get discussion about care pathway and focus of length of stay right from that first review meeting. Even if it's not appropriate to discuss that with service user, which sometimes it does create too much pressure right from day one, there needs to be a shared understanding by all of the care team involved as to whether we're looking at these goals being achieved in 12 months, 18 months or what, so that we're all working towards the same clear goal. As early as possible, we need to start talking to the service user about where they see themselves next. And is it realistic? It could be that they need another placement in the next stage of their journey. It could be that they're looking at housing, but very often if somebody's been institutionalised for 10, 15 years, sometimes longer if they've come right the way through the system, their idea of what is available for housing in what areas does not fit with what is out there. Their ideas of budgeting are usually very warped. And it's these ground level things that can make the success or failure of any kind of transition and care pathway planning for the patient. We've been successful engaging with partner agencies in recent months and working with housing as well as local authority very closely to look at how we can change our discharge planning and how we can engage particularly housing much earlier. We've appointed a new team member to our team in recognition of the difficulty that housing sometimes causes. The plan is now that we will have a housing office to act as a key link with our local housing departments, so that even 6 months before somebody is approaching step down, we can already be looking at not only applications but realistic discussions with the service user, with the right agencies, and also realistic discussions with the agencies, making sure that people aren't put in the areas or the accommodation that is setting them up to fail after a lot of hard work throughout their care pathway planning. That will allow us to work with agencies to identify what the needs are locally, to look at service planning, to start identifying what levels of supporting housing stock are needed, to work with housing to see if there's any voids available in the local housing. Does that allow us to look at a different model of care? Does it allow us to put services into a vacant house rather than actually being frustrated that there isn't a service out there that fits the actual care that we need? So partnership approach is the key to progressing the care pathway right the way through. As providers, obviously, it's not the NHS doing two, it's everybody around the patient working together, and communication is key, making sure that we have the right information, that we have regular information, right from when we're looking for a placement. Do we have communication about where the vacancies are so that we can start looking and saying, well, actually, that unit's got 2 people stepping down in the next 3 months. We've got 2 people coming out of low secure. Providers don't want voids. We want the right patient in the right placement. The same right the way through the care pathway. If everybody's agreed and signed up to where we're looking for step down at what stage, with an overview that the Move On team has as where the vacancies are, we should be able to make sure that the whole pathway goes smoothly and that the right information is provided to the right member of the MDT, whether it's the provider, whether it's the community mental health team, whether it's the housing officer. We provide the overview and the links for good communication. So, and I think that's it from my point of view at the moment.
Thank you very much. Could we show our appreciation, please?